Hi guys, today we're going to talk about diabetes, and this lecture is going to cover multiple different medications for diabetes. And we'll talk a little bit about type 1 and then focus more on type 2. We'll talk about type 1, even though it's really, I think, outside of scope of practice for most people, even primary care. Most people will probably be managed by an endocrinologist of some sort. But it's a good way to talk about insulin and insulin therapy and how that all works. So that's where we'll go. Just some background on diabetes. So diabetes is all about how the body processes sugar and how the body uses insulin, how our muscles uptake sugar, how our liver releases stores of sugar, so like glycogen and its breakdown products, which ends up becoming glucose eventually, which the body gets to use as energy, of course. And all the drugs we use to treat diabetes have different capabilities of manipulating different parts of the system. So some of them might cause production of insulin, some of them might enhance the way our muscles use glucose. Some of them might change the way the liver releases stores of glycogen, and so on and so forth. Just another diagram showing insulin versus glucose and how it all kind of goes in and out of the system and how our body uses it for energy. Diabetes, just like blood pressure, is a long-term killer for most people. I mean, of course, there are people who might get really hyperglycemic in the short term and have kind of an acute crisis because of that. But for the most part, people are going to be experiencing chronic problems because of diabetes, and that's why it's important to screen for it and why we treat it early and fairly aggressively. And again, I think of this as going hand in hand with hypertension. It's a similar process that the body's end organs, similar pathophysiologic process, where the body's end organs end up getting overly taxed. In hypertension, you have excess blood pressure causing damage in the microvasculature and also some of the macro components as well. And diabetes is no different. So I like to think about it this way. Think about extra glucose. You have extra molecules floating around in your body. And over time, if you're trying to push those through small microvasculature, you end up getting damage and blood vessel damage as those glucose molecules kind of damage the vasculature system. Somebody explained it to me once as like tiny shards of glass floating through the body. And so if you think about your body can filter a small amount of that without issue. If you have a large amount chronically over time, those systems fail, especially the kidneys, eyes, again, those end organs. And then that can cause further complications, such as leading to things like neurologic problems such as TIAs or CVAs, so stroke risk increases. And also you have the problem associated with heart failure, acute coronary syndrome risk goes up, so things like increased myocardial infarction. And then you have other complications, I think, again, people think of more commonly as complications of diabetes, so renal issues and ocular problems and neuropathies. Again, we'll spend very little time on type 1 diabetes as far as the disease goes because, again, I really don't think it's something you guys will be managing directly. However, it is important to talk about insulin therapy. So type 1 diabetes is an autoimmune disease. It is insulin-dependent diabetes. So people who have type 1 have to be on an insulin regimen. You cannot, this is probably obvious to most people, but I'll say it just to say it. You cannot use any oral hypoglycemic agents for type 1 diabetes. It wouldn't help at all. That's not the point of treating a type 1 diabetic. You need to supplement the insulin because their pancreas is no longer making it. I've got some statistics here about incidence throughout the world. I think it's kind of interesting. Again, I'm not going to spend a lot of time on this, so you can look at it on your own if you want. Classic symptoms of onset. I'll talk about these now because it's the same thing for type 2 or type 1. If you have excess blood sugar, your body is going to react in the same way regardless of the type. So in this case, you have polyuria, polydipsia, and weight loss are pretty common first presentations of diabetes in patients. Now, weight loss might be different in a type 2 diabetic patient. You might just have symptoms of onset of increased anorexia. The patient might not actually be losing weight, though. But in a type 1 diabetic, you might see weight loss, especially in children who have onsets. Onsets usually for type 1 diabetes is around 4 years old or 14 years old. It's usually one of those two things, and it depends on how fast your body decides to basically kill your own pancreas beta cells that produce insulin. The faster it does it, the faster the onset. So you usually see kind of a dual spike with kids. You see one early in childhood and then one later. But again, getting outside the scope of practice of this a little bit. So insulin therapy, there's a lot of different products available. If you're type 1, you're going to start insulin therapy immediately. If you're type 2, insulin therapy is usually not started unless you want to really aggressively manage the patient. So if they're very out of control, you might go to insulin therapy right away. If they're not, you're probably going to reserve it to later. There's a lot of different products available. There's chronic infusion pumps, or continuous infusion pumps is how I should have said that. And you have a number of different presentations of insulin. Some have more utility in certain diseases than others. Insulin therapy has, for the long time, been what we would call the intensive therapy. So this is pretty much the standard of care, the second bullet point here. The conventional treatment was what was first done when insulin was first developed as a drug, which was more about I guess the regimen was more designed based on the product we had and the kinetics that were associated with it. So the first products on the market were things like just regular insulin. Regular insulin is really just what it sounds like. It's a version of insulin that's exactly the same protein or amino acid sequence as human physiologic insulin. It just happens to be injected subcutaneously. And because of that, it actually takes a little bit of time to absorb. So what they did at first with regular insulin was it was a twice or 3 or even a 4 times a day injection, and you just kind of gave it at scheduled intervals. That doesn't really mimic physiologic processes very well. So what the body does is you always have some basal amount of insulin circulating and ready to go in case you consume any type of carbohydrate. So the body's always ready to respond in a person who has a healthy functioning endocrine system. Now, if somebody, and then if you eat a meal, your body has the capability to respond to increased blood sugar levels by bolusing out insulin from the pancreas. And so that's the idea behind the second bullet point, intensive treatment. So most people who use an insulin regimen will be on some kind of a long-acting basal regimen that they're injecting once or maybe twice daily, and they do mealtime insulin as well. Again, you guys are all nurses, so you're probably familiar with some of this to a certain degree, depending on where you've practiced before. But I do think it's important to get everybody on the same page. Insulin does have some problems, as you might be aware of this already, but more effort's required. You have to be able to inject things into your body regularly, which some patients are going to have issues with. You have a higher risk for hypoglycemia. Anytime you're adding insulin to the body or manipulating insulin, you're always at risk for overdoing it and dropping somebody's blood sugars dangerously low. Insulin is one of the highest risk medications we can give somebody. Not to say it's not safe and can't be used. It's used all the time, as you guys are probably well aware. It's a really common intervention for diabetic patients, but doesn't mean it's not unsafe. In fact, there's a lot of good evidence that shows that insulin, when inappropriately managed, can cause severe adverse effects, including leading up to hospitalization. Weight gain. Weight gain is actually more likely for patients when they start insulin therapy, especially type 2 diabetic patients. So we'll talk about that in a few slides and why that's a little bit of a problem, why that's a problem. But you can probably use your imagination, right? If you have somebody who has other metabolic issues going on, they might be slightly overweight. If you're trying to manage type 2 diabetes, you probably want them to lose a little bit of weight. And adding insulin therapy that might cause them to gain weight is not going to be helpful to that strategy. So in this case, insulin does actually usually cause weight gain in patients. And then the cost. You might have seen some stuff in the news about this recently. I feel like insulin's kind of become a hot button topic, which is interesting because people have been ignoring this for, I think, years, and no one's really been saying anything. And then all of a sudden, a couple of politicians start talking about it, and it's back in the forefront of the media. Is the cost of insulin. Insulin has gone up in cost. Pretty much all types of insulin have steadily increased over the last few years. So one of the insulins that gets a bad rap are some of our mealtime insulins, which are rapid acting. They've been around for decades. They really haven't changed at all. And they're 10 times more than what they cost originally. So why did the price go up that much when the drug is the exact same thing as it was back in the 90s? We don't know. Drug companies trying to make money is probably the bottom line there. But it's become a hot button and a rallying point for a lot of people who are clamoring for lower drug prices in our country and for decreased healthcare costs. When insulin first came out, it was available in vials, and so people would pull out individual doses in syringes, like you can see this man doing here, and injecting it that way. This is still used sometimes, so some products still come in vials, and some patients might find that the vials are less expensive than a pen system, and so they might be doing it for cost reasons too. Also, sometimes you can get higher volumes in the vial, so you might be able to get, like, each pen only contains 3 mils of insulin and a vial contains 10 mils, so they might be able to get overall mil per mil. It might be a lot cheaper to get vials, so you might see patients using the vials and the needles, but most people agree that the pens are easier, and they're certainly a lot safer for patients. So the pens, what you do is, if you've never seen one of these before, you dial one up to the number of units and you inject that way, and then you click the pen while it's injected into the patient's subcutaneous tissue, like you can see here, and that person gets that amount of insulin delivered subcutaneously. It's really that simple. There's a couple tricks to it. You got to wait till it all gets out, so you want to hold it in the body for a little bit while it's injecting itself. But when you compare it to the old method of injecting with a needle, you have to put this in. You have to put a needle. You have to get a needle, uncap it, put it into the vial, withdraw the dose, make sure the dose is correct, and then inject it. Whereas with this, it's a little bit of a no-brainer. You just dial up to the units. It's a lot harder to do this incorrectly. Whereas with this, you have to match the units on the syringe barrel and ensure that you're injecting the right amount. It's much easier to make a mistake using this method than using this method. And pens usually have a max. I think most of them max out at 60 or 80, so you can only inject so many units with each twist of the pen, which can be nice from a safety perspective, but also challenging if you have patients who are on really high doses of insulin. They might have to do multiple injections a day. But most insulins now come in pen form, and that's the most common way we see it done. Okay, a couple different options available. I've got basal insulin, intermediate, rapid acting, and talking about the concentration differences here. Basal insulin is what I was explaining earlier. It's trying to mimic the physiologic amount of insulin that you have circulating in your body at any given time. Basal insulin comes in a couple different products. There's glargine products, Detamir, and degludec products. Lantus isn't the only brand of glargine anymore. There's a couple others, but I just left it there as an example. What you have is a number of different ways you can mix and match different insulin products to get the desired response you want. So again, most people are going to be on a basal plus rapid acting at mealtime. However, the intermediates are used sometimes, and for example, in your patient population, NPH insulin, which is an intermediate acting, is going to be a product that's really popular for OB. It's actually studied fairly well in obstetrics. You guys have probably already talked about gestational diabetes, so I won't go into a ton of detail at this time, but this is a drug that is often used in that population. This shows the different absorptions with different insulins, so you can see that you have, here's your endogenous insulin here. And of course, that's going to be shot out directly from the pancreas into the bloodstream, so it's essentially instantly bioavailable. Everything else has to absorb from the subcutaneous tissue, which usually takes a bit of time. I think some people think of it, well, it's like giving something IV, it's just a little slower. It's actually a lot slower than giving something IV. It does absorb quite well, so you do get fairly high bioavailability. It just takes some time. So you see these peaks around an hour for a lot of these products. And products that are long-acting usually don't have a peak. So they just gradually reach the steady state, and then they just are continuous until they drop off very slowly. Now, some people metabolize differently, so some people might get a little bit more of a peak and a trough with that. So sometimes you do see long-acting insulins, like glargine was designed as a once-daily insulin, but sometimes people give it twice a day just to either spread out the injections if they're on high doses, or they're trying to flatten that basal level in their body so they aren't getting any peaks and troughs. If you do get peaks and troughs on a basal, it's a lot easier to see spikes and changes in blood glucose. So sometimes that's the way to monitor, to modify somebody's regimen to make sure it's more consistent, is to adjust their basal insulin. This chart, definitely don't want you to memorize this or know this for an exam. It's just to show you the differences in insulin, the difference in onset. I get this question a ton, and granted, my background is as an emergency medicine pharmacist and some of the other hospital areas I've worked in. A lot of times we're more concerned with things like, okay, so this person came in and they injected, X number of units of aspart, insulin, and they're hypoglycemic. How long do I have to wait for it to go? But you could very well get that as a primary care practitioner where you have a patient calling your clinic saying, yeah, I injected myself with I accidentally gave myself 2 insulin shots this morning. How long do I have to wait, and how long should I monitor my blood sugar extra to make sure that it's out of my system? So, understanding the kinetics of insulin is really important, especially if you have any patients that are on insulin and are insulin, or either if they're insulin dependent or if they are type 2 patients on insulin. You want to make sure that they know how to react to these situations. Certainly, always refer them to an emergency department or urgent care. That's nothing wrong with that. But telling them, being able to explain, to know the kinetics, so that you can explain some of the durations of action and things like that to your patients are probably pretty important, I would imagine, for most practitioners in primary care. All right, choosing your basal insulin, you've got 2 products on the market. Glargine was actually 3, I should say. Glargine and Detamir were the 2 products around for quite a while until Degludec came out. Degludec is new, came out a couple years ago. But Glargine has been probably the preferred product for a long time. It's a very steady state insulin that doesn't really have a huge peak or a trough until it wears off. So theoretically, you inject it every day and you really just get a basal level with no peak or trough. Again, I said some people's kinetics vary. Some people absorb it faster from the subcutaneous tissue, some people slower, so it could make it so you want somebody to do it twice a day. I've never seen Glargine 3 times a day, but twice a day isn't uncommon. Once a day is probably the most common way you'll see it dosed. A couple different products on the market. Lantus has been the one that's been around forever. It was the first one. Basaglar is a different company that makes other types of insulin that got on board with Glargine once it was able to produce what's called a biosimilar. So insulins are technically biologic products. They are peptide chains. So if you have a product that's for the longest time, our biologic products didn't have the same patent rules that small molecule drugs were. So it wasn't like after 10 years you could just make an insulin. That company basically owned that patent for life. A few years ago, I think during 2014, there was some legislation passed allowing biologic agents to be produced as a somewhat generic form, and I use that term loosely because it was called biosimilar. So biologic products are more expensive to produce in general, but the problem is that if somebody always has a patent on it, there's no competition for the product. So now we're seeing some Glargine alternatives coming out. So Basaglar is insulin Glargine, it's just rebranded differently. Toujeo is insulin Glargine, and it's rebranded differently, but it's a U300 concentration. U300 or U100, what this means is it's how many units per mil of insulin. So most insulins come as U100. They're 100 units in a mil. Toujeo is a more concentrated product. It's 300 units per mil, which makes it maybe inherently a little bit more dangerous. However, again, it comes as a pen, so you're dialing back to the unit. And what I would say is that it's really convenient for those people who are on really high doses. So sometimes you get type 2 diabetic patients that are on just massive doses of insulin, and they might be going through, a pen every 2 days of Lantus, so that's 300 units total. They might be injecting half of that in a day. I've definitely seen patients on doses that high. If you have Toujeo, you have a lot more units in a concentrated volume, and you have the same amount, 3 mils, but it's 900 total units of insulin in the whole pen versus 300. So you can get by with either lower amounts of injectable insulin, which is handy, and also the pen lasts a little bit longer for patients. Degludec is Tresiba is the brand name, comes as a 100 and a 200 unit concentration. It's got a 25-hour half-life and takes a few days to get to steady state. It's new, but it's approved for both types of diabetes. There have been studies that show that people who take Glargine get nocturnal hypoglycemia, and some of the reason is because most people take Glargine in the evening. They inject it, their once daily shot in the evening, and then Glargine does have a very subtle peak to it, and so some people do get a little bit more insulin activity overnight. And if you aren't eating overnight, right? So while you sleep, some people will notice that they get hypoglycemic in the middle of the night. Degludec or Tresiba has shown that that is not as big of a problem with it. So that's one of the selling points of that basal insulin. Detamir is an older product. Its half-life's less, and it's really variable kinetics compared to glargine and degludec, and it's usually dosed twice daily for most patients. I don't think I've ever seen it once daily. Mealtime insulin, glulisine, aspart, and Lispro are all basically the same. Insurance is going to pay for one, pick that one, and they all come as U100, except for Humalog. Humalog is aspart. I don't have that in here, but it is insulin it's insulin Lispro, excuse me. And it comes as a newer product that's a concentrated version of it too. So again, for those people on higher amounts, it's a handier option. Onsets are fast, peaks are fast, duration should be relatively short. Other insulin options, there's NPH, BID. NPH is a longer intermediate acting product, and sometimes you'll see people on a twice daily. NPH is relatively inexpensive. Sometimes if you have somebody who just can't afford Lantus and mealtime, or they are having issues with multiple, like three or four daily injections, or even 5 daily injections if they're doing some at bedtime too, with like a bedtime snack. NPH BID is sometimes used. It's not an ideal regimen, but it is an option. You guys have probably talked about this with respect to gestational diabetes, but it is a choice for patients out there. Regular insulin 3 to 4 times a day, again, not super recommended anymore as a chronic option for patients, but it is something that's used. Regular insulin does come as a U500 product, which is a 500 unit per mil concentration. It's super dangerous. It's very concentrated. Whenever we get a patient on it, we have to make sure we have a lot of checks and balances in place. That's all I'll say about that. You guys should never be prescribing U500. It's something that would be a specialist prescribing only. Levemir and glargine, twice daily Novolog. So you see this type of a regimen where people take their basal insulin twice a day. And again, I talked about that, why some people do that for the kinetics, just because they're getting peaks with the glargine. There's a lot of mixed combination products out there on the market, which we get into the weeds a little bit, and I'm not going to talk about them, but they're there listed for your information in case you're curious. I'm not going to spend any time on designing a regimen for a type 1 patient because it's just, again, it's out of scope, but you can see here, it's weight-based. You base it on total daily needs, and then you adjust based on your initial regimen. Mealtime insulin is usually done as a couple different options. The most common way is carb counting, and probably the most correct way is to carb count. So you carb count with every meal based on the units of carbohydrates you're eating. Usually it's like 3 units per carb choice. And then you usually have a sliding scale that you can do on top of that. So if somebody, let's say somebody's mealtime, they're eating 5 carb choices, so it's going to be 15 units they're going to inject. And let's say prior to their meal, their blood sugar is 210, then they'd be adding 2 units on top of that. So that's a common example of how sliding scale, like a carb counting plus sliding scale, works. Some people just don't do carb counting, or maybe they eat really consistent meals, or they aren't capable of carb counting. They've tried it, hasn't worked very well. I'd recommend having a dietitian involved with a lot of these cases, but if the patient's still having issues, you can try fixed dose mealtime. So somebody might just be on, like, for example, 10 units per meal, and that just might be it. They might do a sliding scale, but again, it depends on their capability and ability to do multiple different processes with each meal. So can they carb count and can they sliding scale every meal? No, they can't. Well, let's try fixed. Could they maybe add a sliding scale after that if the fixed isn't working? Blood glucose monitoring. You guys are nurses. You probably all use these at some point, hopefully, in your career. I'm not going to talk about them a ton. Most people test around 4 to 7 times a day. There's really cool technology with these. A lot of them sync directly to smartphones via Bluetooth. There are patches, or I call them patches. They aren't really patches. They're like devices that you can put on people's arms or wherever they want to wear them, and they can continuously communicate with the phone periodically, and they last for a few days. That's more expensive than traditional testing, but it's a lot better than sticking your finger every day for a lot of patients. So there's a lot of cool technology out there. We're getting closer and closer to the point of having some sort of artificial pancreas almost, right? Where you have something like this that you have attached to the body continuously monitoring your blood glucose. And then you have an infusion pump that will respond to that. So like this example here, you have a sensor here that's measuring blood glucose. It's communicating wirelessly with the pump, tells the pump, okay, so we need to increase our basal rate a little bit because the blood sugar is getting a little bit high. It'll increase it or it'll decrease it depending on what the sensor is picking up. So again, it's basically working like how the pancreas does endogenously. So that's some of the cool technology we're coming out with. Unfortunately, I think the way the general population is responding to these, a lot of people have been buying older pumps and quote unquote hacking them into being able to do this, whereas the technology and the FDA approval processes are lagging what people are doing in real time. So it's kind of an interesting thing, but I'm not going to talk about that anymore because it's mostly related to type 1 patients. Infusion pumps can be used for type 2 patients, though. So for people who are using insulin to manage their type 2 diabetes, they might be on a continuous infusion. Or if you have a patient on an infusion pump, certainly you might run into younger patients who are of childbearing age who have infusion pumps. So it's probably worth just talking about them a little bit. Infusion pumps essentially are just providing basal insulin, but they're using rapid acting. So you fill a pump with Aspart or Lispro or Glulicine, and it's continuously infusing that very slowly, and then you can bolus off the pump for meals, or you can program it to do different things. That's basically it. Pumps are really nice for patients. They usually end up using less overall insulin by about 10 to 20% than if you were to do an intensive injection regimen. So your blood hypoglycemia risk is less. Your overall insulin use is less as well. But pumps, I think people think, well, a pump is great because you just hook it up to somebody and kind of forget about it. It's good for patients who might be having adherence issues. And actually the opposite is true. People who have pumps really need to be on top of them. If the pump malfunctions, it can be deadly. I had somebody come into the ER a couple months ago, and his blood sugar was like 60. And it was actually when he got to the ER, and it was actually lower than that before. And the physician asked me to go in and talk to him, and so I was working with him, and I looked at he had been recording his blood glucose in his phone app when he was taking his blood sugars, and it was showing him as in the 300s the night before. So the pump was way overcompensating for those high doses, and then it was not giving enough when he needed it. So he was getting, basically this pump was totally malfunctioning on him, and fortunately he came into the ER and we were able to catch it, but easily could have been a hypoglycemic emergency. I mean, it was really because he was in the ER, but I mean, it could have been much worse than that. But very convenient for a lot of patients who are managing diabetes chronically, especially type 1 patients. But certainly you can do pumps in type 2 patients as well. Hypoglycemia, you guys are nurses, you know all this stuff, right? Blood sugar less than 70, those are the symptoms. Give some sugar, that's pretty much it. We do have some specific types of oral glucose that are designed for this, so like glucose gel or wafers. But if somebody doesn't have that available, pretty much, I mean, the world's full of sugar, right? It shouldn't be that hard to keep some sugar nearby. In severe cases, or like ambulance rigs would have IV dextrose, and that's what we'd use for patient. IV dextrose is not convenient for somebody to carry around with them. It requires IV access. It's 50 mils of liquid. So it's really only a hospital strategy or a EMS strategy. People on the outpatient side can carry around a glucagon kit. Glucagon, as a peptide hormone produced by pancreatic alpha cells, it works and it is released endogenously when blood glucose is low. So if you get hypoglycemic, you can inject a synthetic version, and that should help mimic some of those emergency responses like your body would do. DKA and HHS I'm not going to talk about. They're a little bit out of scope for, I think, this talk, but the information's there in case you're curious. All right, let's talk about type 2 diabetes. And type 2 goes along with a lot of other cardiovascular issues, and there's a lot of things that I think augment the effects of type 2 diabetes. So smoking, overweight patients, sedentary lifestyle, high blood pressure, high fat and cholesterol diet. This is just infographics about sugar and risk. Yes, sugar is sugar. It all kind of does the same thing. Anyway, increasing your body weight increases risk of diabetes. Here's just some charts and statistics showing the correlation between impaired glucose tolerance and weight. All right, so type 2 diabetics type 2 diabetes affects about 8% of the U.S. population. About 25 to 40% of patients remain undiagnosed. So if we increase that by 2 to 4% or so, you've got a fairly large, you've got several million people in the United States with type 2 diabetes. So it's a very common disease. It's something you're going to see in every facet of primary care. And so that's why we'll spend a little bit more time on it than we did type 1. Normal labs, fasting blood sugar less than 100, A1C less than 65. Screening criteria, usually if somebody's A1C is greater than 6.5, their fasting blood glucose is more than 126, or they have a 2-hour blood glucose with oral tolerance test greater than 200. That's when you're going to probably go down the path of starting some medication for type 2 diabetes. Hemoglobin A1C, if you've never talked about this or never heard of this, hopefully you've heard of A1Cs before, but you might never actually discussed what it is. So hemoglobin binds glucose molecules, and so A1C is a picture in time of, I think, if you think about it, like you can see about 3 months worth of blood sugar data by looking at a single A1C percentage, whereas a blood sugar in of itself is very isolated. You can't really get a lot from one blood sugar. You have to look at the trends, and that's what A1C does. A1C is basically giving you a picture of a trend in one nice, easy to read lab value, whereas you don't have to interpret 3 months of pump data or blood glucose meter, glucometer, I should say. I'm trying to think of the word there. Data for 3 months. So anyway, the more blood glucose bound to hemoglobin, the higher the percentage of hemoglobin A1C. All right, so this is a chart that's probably pretty small to read, but hopefully you guys can see it okay on your screens. What I'm showing you here is a couple different recommendations from different organizations and different patient populations as far as what the A1C should be. And the point of me showing you this is not to confuse you, but to show you that the world doesn't necessarily agree on things. And so, as you guys probably are well aware, but there's two major sets of guidelines, the ADA, American Diabetes Association, and then the AACE, which is an endocrinology group. They have a little bit different opinions on what the goals should be. Generally speaking, AACE is more aggressive, especially like if you look at pregnant patients. So pregnant patients, ADA says less than 7.5. This one says less than or equal to 6. So they actually have a really tight goal for pregnancy. But overall, you can see it's fairly similar. That's pretty much the biggest outlier, but they are a little bit more aggressive on the whole with their A1C goals than the ADA is. Non-pharmacologic options. So diet, exercise certainly should be recommended to all diabetic patients. There are a small percentage of people that can manage their diabetes with this alone, but most patients will need medication. There was a study in the UK, a really big study that looked at a couple dietary parameters, and only about 3% achieved fasting blood glucose goals. And they found that with exercise programs, you see results with them right away, but compliance is very difficult to catch up. I mean, that's one of those studies where you're like, did you really need a study to figure that out? But it doesn't mean that you shouldn't encourage your patients to do that, even though the data would say that it's very difficult to sustain benefit long term with this. Behavioral counseling is really important. Recommending these things, I think, is really important for the patients, but at the same time, you want to make sure you're working with their lab values as well and getting them into the goal range they need to be. So that's where medications come into play. All right, metformin is glucophage. As nurses, you guys have all seen somebody on metformin. I would wager $100 that that's true. Hopefully I wouldn't lose my money, but I'm pretty confident metformin is probably one of the most popular drugs on the planet. It's used a lot in diabetes for good reason, and its mechanism is pretty unique actually when it comes down to it. So what metformin does is it decreases hepatic glucose production, it decreases intestinal absorption of glucose, and increases peripheral glucose uptake and utilization. So it works on a number of different areas of glucose optimization within the body. However, you'll notice that for its mechanism, it doesn't do anything with insulin. It doesn't increase the body's production of insulin, it doesn't cause the pancreas to release insulin. That's why people love metformin. And if those guidelines differ on a lot of things, one thing they both agree upon is you always start metformin first for every patient. Metformin has a great track record with people. It reduces A1C by up to 1.5%. It's first-line therapy again. Contraindications are relatively few. It does have a couple. If your serum creatinine is over 1.5 in males or over 1.4 in females, it is contraindicated. So if your patient has some kidney function decline, or they're going to go in for an iodinated contrast media or surgical procedure, it is contraindicated for those patients. The magic of recording lectures online. I noticed that I made some updates to this lecture this year, and I forgot to change the contraindication. So it used to be the serum creatinine rule. Now it actually is estimated GFR less than 30. So you don't have to remember weird numbers for men or women. It's one standard thing, but everything else is the same. The big side effect with metformin, lactic acidosis is super rare, and there's a lot of debate whether it is even caused by metformin or not, so I'm not going to talk about it. GI side effects are what people are going to complain about with metformin. They're going to get diarrhea, nausea, and vomiting, and flatulence, 10 to 50% incidence depending on which study you read. I always recommend you start people out on metformin with the extended release product because it's less likely to cause some of these GI side effects. And the extended release product is quite inexpensive. It's been generic forever, just like metformin has. You shouldn't really have any cost issues with it. So I always tell people if you're going to start metformin, you might as well start the ER. It's going to be better tolerated for the majority of patients. Sulfonylureas have been the historic second line option for people, and current guidelines disagree on where to use them. But they are very effective. They reduce A1C by 1 to 2%. Their mechanism is very different from metformin. It stimulates insulin release from the beta cells, and then it has some other things too. But basically, it's a heavily focused on its mechanism, and its effects revolve around insulin. And if you have poor renal function and metformin doesn't work with you, you can take a sulfonylurea. So that's been also a first-line agent for some patients who have kidney issues. Side effects, hypoglycemia is pretty high with these. It's probably the highest of any of the oral the oral hypoglycemic agents. It's probably got the highest hypoglycemic risk. And it does cause weight gain, which is a concern for a lot of patients. And it thought theoretically and maybe in actuality to have some increase in beta cell failure. So that's why, for example, the Endocrinology Society doesn't like using these drugs at all, really. They want to reserve them pretty much for a last line therapy. So the reason is because the theory is that if you're pushing medications that cause the beta cells to produce and release insulin, you're overtaxing that system, and you're going to over time accelerate the disease state. So your pancreas is basically going to shut down on its own because you're overtaxing it with medications. In the short term, you get good benefits, but long term, there's issues with them. So they'll advocate for not using these drugs right away because of that reason. Here are the drugs. There are a couple different ones. They all start with GLI. Pretty easy to remember their names, I think. And there's a couple that are renally adjusted, but like glipizide is the most common one. It doesn't require any adjustment. So just with the hypoglycemia risk, after exercise or a missed meal is the highest risk. So if somebody's not going to eat breakfast in the morning, they probably shouldn't take their glipizide until they're going to eat a meal. High dose, long-acting med, or impaired renal function all increases the risk. So if somebody's on an extended release product, that's going to increase the risk too, especially if they aren't eating a lot of food. Thiazolidinediones are a couple drugs, pioglitazone and rosiglitazone. Rosiglitazone was removed from the market in Europe, highly restricted in the U.S. due to a perceived increased risk of myocardial infarction. However, that risk recommendation was reversed in 2013. Anyway, these drugs are PPAR gamma agonists, which they activate genes involving glucose and lipid metabolism. They have improved target cell response to insulin too. They have some A1C lowering benefits. They're a little bit all over the place, 0.4 to 1.4%. Side effects, weight gain, fluid retention, and bone loss. So weight gain puts a strike against it. Fluid retention is difficult for patients who have edema issues or have heart failure specifically. And bone loss for people at risk for osteoporosis. So some reasons not to use these drugs. DPP-4 inhibitors. Sorry about all the names of these hypoglycemic agents. Believe me, I'm not the one who came up with all this stuff. I wish. I probably wouldn't be doing this right now. But DPP-4 inhibitors are a group of drugs. I call them the gliptins because they all end in gliptin. And the mechanism is prolonged incretin hormone levels. So dipeptidyl peptidase 4 enzyme inactivates incretin hormones, and incretin hormones regulate glucose homeostasis, which help increase insulin secretion from the beta cells. So again, ultimately you have a mechanism that's revolving around insulin secretion. Modest A1C lowering, they're expensive. They have a low hypoglycemia risk, and they're really well tolerated. There is some maybe joint pain. There was 33 cases over a 7-year period, so the FDA put a warning on it. And then maybe increased hospitalizations with some CHF patients. But overall, very well tolerated with for a lot of patients. So it's a nice option for people who have been having issues with hypoglycemia and other agents, especially sulfonylureas. And they do have some synergistic effects with metformin. So the idea is, yes, they might get 0.4 to 0.6 on their own, but if you give them with metformin, maybe you can up yours into the 2 to 3% range as far as dropping. So they're pretty popular drugs overall. They are mostly brand name and fairly expensive, though. The SGLT2, or sodium glucose cotransporter, you can remember SGLT2 if you want. I like to just remember as the sodium glucose cotransporter drugs. So that helps me remember exactly what they do. These drugs basically make you filter out or reduce resorption of filtered glucose. So they have you pee out extra blood sugar. That's really all there is to it. Basically, you end up losing about 200 to 300 calories per day, which is 2 to 3 kilos of weight reduction over 6 to 12 months, and that's sustainable for 2 years in their current research. So these drugs have some nice advantages in losing weight. They do work heavily with the kidneys. If your kidneys aren't functional, these drugs won't work. So you have to be able to get the drug to the point of action. It's not recommended for anyone with a GFR less than 60, but for sure not less than 30. In between 30 and 60, it's kind of like, do you use them or not? The evidence isn't clear. As far as side effects go, there's a lot of them. The hypoglycemic risk is low. However, everything else is a little bit bizarre. So these kind of, I think of these sort of like a diuretic because, well, they aren't directly a diuretic. They're increasing glucose excretion in the urine, and some water will follow that too. So they do cause some diuresis. So people can get hypovolemic. You can get electrolyte disturbances. You can have increases in serum creatinine and acute kidney injury risk. People have seen increases in LDL cholesterol, which I'm not entirely sure how that's possible, but that one doesn't really make sense with me. The infectious disease related ones are kind of interesting. So fungal vaginosis, UTIs, dysuria, and balanitis in men are all fairly common incidences with these. And it's because you think about the concentration of glucose in your urine is increasing. So any opportunistic bacteria or fungi that live in the genital tract or the urinary tract, just naturally, well, nothing should live in the urinary tract, right? But in the genital area or outside of the body immediately, those can overgrow if they have an increase in food source, which they would with the sugar. So that's the concept behind that. Increase in bone fractures, twofold risk of leg and foot amputation for diabetic patients. Why? I don't know. Diabetic patients are always at risk for amputation because of the microvascular complications and foot ulcerations and things like that. But why it's a twofold risk on these, I'm not entirely sure. The benefits are modest, but they have showed some positive. Sorry, this kind of got cut off on the blue stripe here, but it says positive mortality benefits and CV outcomes here. And I think this is going to be an interesting drug class to follow because I think the researchers are really pushing this into the CV arena. Because if your drug crosses over from diabetes into cardiovascular protection, you've got a real blockbuster on your hands. So these drugs, I think at first people are like, "What's the point of this? It's got modest A1C lowering. It gives people UTIs. Like, I don't really know." But the more I think we see different information coming out, the more these drugs look a little bit more appealing. So where I would use these is like a younger patient who maybe wants to lose some weight and is diabetic. These are a really good option if they have healthy kidneys. Of course, you got to watch out for the infectious disease related things, but outside of that, they're pretty well tolerated. Where I would say just a word of caution is these are brand new drugs, relatively speaking, and they are really expensive, so insurances might not pay for them. GLP-1 agonists are glucagon-like peptide. What they do is increase glucose-dependent insulin secretion. They decrease inappropriate glucagon secretion and slow gastric emptying and decrease food intake. So they have a couple different mechanisms. These have become a lot more popular in recent years, and there's a lot of drugs available. The original one is exenatide or Byetta. And the short-acting ones have really fallen out of favor. So really, if you're going to prescribe these, you're going to be looking at the long-acting medications. They're all sub-Q injections. They kind of look like insulin pens, as you can see. They aren't, but that's the same design they have. It's kind of a smart idea for the drug company to make it look like something that patients who are diabetic might have already been using. The sub-Q injections are pricey. These products are biologic agents, so they aren't small molecule drugs, so they're going to be some of the more expensive ones we're talking about. They do lower A1C by 0.5 to 1%. Dosing schedules are variable. Some are every day, some are once weekly. Some advantages, they may help with weight loss, very low risk of hypoglycemia, And some of them have started to show cardiovascular benefits. So again, see some of these newer drugs, and they're like, well, what about the cardiovascular benefits? And can we prove that these drugs not only lower A1C but have better benefits outside of diabetes treatment? So the drug companies are trying to get all over this right now. I think again that's going to be one of the pushes we see as some crossover from some of these medications into some other disease states where currently they aren't recommended just for that use, right? Side effects, GI related, nausea, vomiting, diarrhea. They're renally eliminated, so that could be a problem. And some thyroid tumors have been seen in animal models, which hasn't been replicated in humans. Meglitinides are repaglinide or neteglinide or Prandin and Starlex. These ones aren't super common, but they do have a somewhat unique mechanism there. Block ATP-dependent potassium channels, facilitate calcium entry into beta cells, and stimulate glucose-dependent insulin release. They have slightly or less effective than sulfonylureas, but similar. They have really low hypoglycemia risk. So, for example, the ADA would say if you have somebody who has erratic meal times or is having issues with hypoglycemia on a sulfonylurea, to use one of these drugs. They're brand name only. They're quite expensive, so they don't get a ton of play. I'm going to skip this class altogether because they really aren't used. They cause a lot of flatulence and diarrhea. They work in the GI tract, and people don't tolerate them very well. We have a lot of other drugs available, so skip that. Insulin in type 2, historically, it was reserved for failure of several oral hypoglycemic agents, and this is still pretty much the practice. For most of the guidelines will say for mild type 2 diabetes, you start with oral agents, and then you'd only start somebody on insulin or give insulin if they had really high blood sugar. Treatment is very similar to type 1. However, a lot of times in type 2, you don't start somebody on mealtime insulin. You just start them on a basal regimen. You can add mealtime if you think it's necessary, but most patients will be started on basal. Usually, they'll be on oral hypoglycemics as well. So most patients should probably be on metformin in addition to their insulin. And intensive strategies, increased doses, continuous infusion pumps are all options for type 2 patients. You just move up as needed based on how intensive you want your strategy to be. I put this chart in here from Up to Date. It's kind of the old school way of treating diabetes, and I still think it's nice and easy, so that's why I do it. At diagnosis, you start with lifestyle benefits and metformin. If that doesn't work, you try, they would say add basal insulin on, or add a sulfonylurea, and then after that, you could go to intensive insulin, or you could go down to here and try some of these other options. The different guidelines are a little bit more specific. So this is the ADA recommendations right now. You consult patients on healthy eating, weight control, so that's your lifestyle. You initiate metformin. So here we go again with metformin. If you don't get your A1C achieved in 3 months, consider adding a second agent depending on patient-specific factors and drug characteristics. Consider initiating therapy at this stage if A1C is greater than or equal to 9%. Somebody comes in with an A1C of 10, they're saying you start somebody immediately on 2 drugs, or an A1C of 9.5. Let's just say that. Start somebody on 2 drugs right away. If they come in with between 6.5 and 9, then you just start them on metformin. So that's the breakdown here. Now, ADA is putting these all on a flat plane, and they're saying these are all equivalent. There's all good evidence that these drop it. Look at your patient risk factors here. So again, let's say you start somebody on metformin, you aren't getting your goals, and the patient is younger, they have good kidneys, they want to lose weight. SGLT2 might be a good option. Maybe weight loss is important to them as well, and GLP-1s are covered. Maybe you go with that. I don't know. There's not really a specific plan here, and ADA has recognized that all these drugs might have utility in different patient populations. So they're kind of leaving it up to you as the clinician to say, all right, what's the best choice here going forward? They still do sulfonylureas as a second-line option and basal insulin as a second-line option as well. So you could really pick a number of choices within the ADA guidelines. So if that's not achieved, you don't get your goal within 3 months, consider adding a third agent. And so here's where they say, so let's say, so again, you've got metformin on board for all these. So if you picked, and this is where they stratify a little bit. So if you picked, let's go back to our younger patient. So, whoops, moving stuff around here. So let's say we added, as an example, we started with metformin, we added the SGLT2, then they would say put a sulfonylurea on board. They actually go to sulfonylureas as a third line option for almost all their patients, with the exception of a few here. The only ones they shy away from, you can see they shy away from sulfonylureas if you're already on insulin. That's because of a compounded hypoglycemia risk, so they're a little bit worried with that there. And insulin's the last choice once you're factoring in the sulfonylurea. So that's one of the things they take into consideration in their guidelines and recommendations is stacking sulfonylureas and basal insulin increases your risk of hypoglycemia substantially. It also is a heavy insulin dependent regimen because you're manipulating the pancreas and you're giving insulin at the same time. So they don't think there's as much synergy there. If your A1C not achieved after 3 months, patient is on oral combination, you move to injectables or this and add basal insulin, optimally titrate your insulin. Consider starting at this stage so if your blood glucose is really high or A1C is 10 to 12%, then you would maybe start at a more aggressive one. So there's the ADA guidelines. I think they're pretty straightforward. I think it's a little hard for when I taught this to my PA students, for example. It's a little bit, sometimes it's challenging because they're like, well, there's not really a clear-cut pathway here, and there isn't. Diabetes is a little bit tricky. There's a lot more classes of drugs than, let's say, hypertension, and you have less evidence to say one or the other. You have a lot more newer agents that we don't have as many good long-term benefits with. So you do have to really look at your patient and figure out which one's going to be the best option for that specific individual case. You also have to take cost into consideration. I took some flack once because an endocrinologist was teaching and was saying something about, well, the GLP or sorry, I can't even say the drug classes. The GLP-1s are really great. I always use those. Well, they're really expensive, and not everyone's insurance is going to pay for those right away. So I really do think you need to take cost into consideration too. It doesn't mean you can't prescribe something. You can certainly try. Just be prepared that you might get a phone call from the pharmacy saying, sorry, we don't cover this agent. Although a lot of these drugs, as they get newer, they get more integrated into guidelines, insurance formularies pick them up, but especially the brand new ones or the ones that are really just unknown for now, you might have some more difficulty getting those covered. All right, these guidelines are the AACE guidelines. So you have lifestyle therapy, including a medical assisted weight loss, and you have the different A1Cs stratified there. So again, they're a little bit more aggressive here. If your entry A1C is less than 7.5, you're going to do monotherapy. And here they actually stratify it. So this is in order of what drugs they like the best. So they're always going to put metformin on top. So again, that's a great thing about the guidelines. They all agree that metformin's the first line choice. If you couldn't tolerate metformin, they actually go to GLP-1 right away. And then they go to the SGLT2s. So you're seeing a different school of thought here where they're using some of these newer agents that have weight loss associated, possible cardiovascular benefits. They're putting those above some of the older agents. Like you see a sulfonylurea way at the bottom here. And again, sulfonylurea is at the bottom. They don't like them. Whereas we just saw that ADA still thinks they're a practical therapy for patients. Entry level greater than or equal to 7.5, you're going to start dual therapy. Remember, ADA was 9, you start dual therapy. So again, much more aggressive with AACE. And greater than 9%, you're going to do triple therapy, which again is more aggressive. So they'd say 10 to 12% for ADA. You have metformin plus another first line agent plus a second line agent. So you're looking at like metformin, GLP-1, SGLT2. Symptoms, if you have no symptoms, dual therapy or triple therapy might be considered. So they are saying that for over 9, they generally recommend triple therapy as an option. If you aren't symptomatic, but you just have a high A1C, dual therapy might be acceptable for those patients. If you're symptomatic, they might say that insulin plus some of the other agents would be the first line. So they're giving you some wiggle room as to how you want to model your treatment regimen for your patient in this category, depending on what kind of symptoms they have and how severe their diabetes is. All right, gestational. I'm pretty sure you guys have talked about this in other classes, but of course there's the tolerance test that you're probably all familiar with. You take 50 grams of glucose, your blood sugar's after 1 hour. If it's less than 130, you pass it. Fail it, you do 100 grams of glucose and take a blood glucose after 3 hours. Medications that are okay in pregnancy, insulin. Lispro and Aspart have been studied in pregnancy, so those short-acting mealtime insulins are okay. Long-acting, and again, NPH has the best data. Likely, most insulins are safe in pregnancy. I don't think very many cross the placenta. However, it is something that when it comes to pregnancy, as you guys are probably learning, some of the drugs don't match up with what we do in standard adult medicine because we just don't have evidence to support it. So again, NPH has the best data, so oftentimes you'll see pregnant patients on NPH as their longer acting insulin. Oral agents, glyburide is probably the best studied one out there. It's not as effective as insulin. Metformin is also used. It appears to be safe in second and third trimester. It's kind of unknown in the first trimester, but most patients who are diagnosed with gestational are probably not being diagnosed in the first trimester, right? It's probably not caught until the second trimester or tested until they're at least closer into the second trimester. Other pregnancy considerations, basal insulin dilemma. So glargine and detamir have not been significantly studied. So again, you don't really have a basal insulin that has really good data associated with it in pregnant populations. And I don't know if that'll ever change, but right now, glargine has some concerns, has this constant basal rate, which may not be ideal for changing daytime and nighttime basal needs in a pregnant patient. Onset might be slow to be useful if acute changes are needed. So if somebody is over medicated on the insulin, if you overdo the glargine, you can't reverse it. Whereas NPH, if you overdid it, it's not as long lasting. So that's one of the concerns of glargine. Detamir recently changed to category B and has been shown to be non-inferior to NPH in at least one study. I think it's something that could be considered. It's a little bit, I think it's a better option if you want a more steady state than NPH, but also it does have some of the concerns with glargine where it's going to last longer than NPH. So you do have to be careful with how much you're using because you can't reverse it. Well, you can just give sugar, I guess, but that's not ideal. So with that in mind, I think that there's diabetes is a little bit complicated. I would like you guys to understand the basics and of course focusing on your patient population. So the pregnancy related information, know the basics of an insulin regimen, like what an intensive insulin regimen is versus like a twice daily NPH regimen, why there's one that's better than the other, mimicking physiologic processes or not. Know the drug classes and know some of the drug names within the classes. I really do think it's important, especially if you plan on having primary care as a component of your midwifery practice. You're really going to want to know these drugs. Diabetes, again, is so common that you're going to see patients on all of these drugs. Even though it seems like a lot, it's probably worth your time to put in and invest into knowing these. Are you going to see everyone and have to know every side effect? No, but I would like you to know like which ones cause weight loss, which ones like where would we use a drug in a certain class? So what's the risk with giving a sulfonylurea? Why have those fallen out of favor with certain guidelines? What drugs might have some possible cardiovascular benefits? So things like that are important for making decisions when prescribing to patients, and that's what you'll see on the exam. So with that in mind, if you have any questions, certainly email or ask on the forums, and I'll talk to you guys via lecture soon. Thanks.